So I was one of the 16 people that was selected to participate in a 6-month adventure with the National Academies of Sciences, Engineering, and Medicine of the United States at the end of 2016. I do have some disclosures to make as a member of this committee. During the time I was participating on the committee, I had to divest myself from all my consulting agreements that I had. And ultimately, this is the product. This is the front cover of the volume that we published in January of 2017, culminating a very brief 6 months of work. Usually our National Academies of Science, Engineering, and Medicine committees work for 2 to 3 years, but this was felt to be somewhat emergent because the data that we were asked to produce was felt to be necessary. It was thought that the elections in the United States in 2016, which produced many surprises, we're going to see more states approving cannabis for medical or recreational use. And the Centers for Disease Control of the United States was concerned that the last volume produced on this topic by the Institute of Medicine in the United States was published in 1999. So they felt that that was a bit outdated. Actually, the first time that this was looked at by this august government body, they published a volume called Marijuana and Health in 1982. And I'll just give you the main highlight, or one of the highlights that I took away from reviewing that volume in 1982, was that the authors of this report suggested that cannabidiol be investigated as a treatment for seizure disorders in children. 1982, it took how many years? 37 years until that actually occurred. Again, 1999, the group Institute of Medicine published Marijuana and Medicine, assessing the science base. And again, 1999 to 2016 is a long time. And in that interim, I approached the leadership of the National Academies and I said, you need to update this because it's old. What I didn't realize is that you need money to do that. And so they waited until a number of government organizations got together and said, we need to update this, and provided the money to support the project. So the goal that we were asked to achieve was to develop a comprehensive, in-depth review of the existing evidence regarding the health effects, both harms and benefits, of cannabis and cannabinoid use. Now let me just look at a few of the words there. So, as I mentioned yesterday, for those of you that were here, the only legal source of cannabis to study for research in the United States comes from our National Institute on Drug Abuse, NIDA. And NIDA has a congressional mandate that they can only study substances of abuse as substances of abuse. So if you want to study cannabis as a potential therapy for something, you must use NIDA cannabis, but they cannot fund that research. So you have to find funding elsewhere. On the other hand, NIDA spends $150 million a year supporting research looking for the potential harms of cannabis. So there's a little bit of a disconnect. And then because much of the published literature is not about research investigating the plant itself, but delta-9 tetrahydrocannabinol, and in some cases cannabidiol, we talk about the health effects of cannabis and cannabinoids. And those are the two main cannabinoids that we found published in the medical literature. Our second statement or goal of the committee was to make short and long-term recommendations regarding a research agenda to identify the critical questions and advance the cannabis and cannabinoid research agenda. So I mentioned money, and these are the people that supported the work. Again, the Centers for Disease Control and the National Cancer Institute, as well as the National Institute on Drug Abuse, NIDA, were all prominent in supporting this work. And then most of the states where cannabis had been legalized for recreational use, or was going to be legalized for recreational use, also helped fund the project. The committee, 16 of us, had expertise in the areas that you see here. Interestingly, when I got to my first meeting, I said, wait a minute, I'm the only person here who studies the potential beneficial effects of cannabis. Everybody else studies the potential harm, and I felt a little bit overcome, but I think it was pretty important that I was present on the committee. And we met 2 days a month, June, July, August, September, October, November, and December in Washington, D.C. For 2-day meetings. 2 of our meetings were so-called open sessions where other people who were not on the committee were invited to attend. And what we did was we were asked to look at all the literature published in the medical databases since 1999, the last time that the Institute of Medicine issued their report that had cannabis, cannabinoids, delta-9 THC. We developed a long list of words, and we put that into the computer, and it spit out 24,000 article titles, of which we then weaned it down to 10,000 that we reviewed. Not each person reviewing 10,000, but the committee was split, and the real primacy, the main articles that we were asked to concentrate on were so-called meta-analyses or systematic reviews. And that means if people look at, does cannabis cause schizophrenia, for example, there have been many, many studies of does cannabis cause schizophrenia, and a meta-analysis or a systematic review looks at 20 of those studies and combines all the data and gives us an overview of the sort of average outcome or the results of this collection of clinical trials or observational research. Let me just say another point about the difference between research on the therapeutic effects of cannabis and the harmful effects. When I do a study to look at the effect of cannabis on pain, for example, the gold standard of clinical research is the randomized, placebo-controlled, double-blind clinical trial where, every person gets randomly assigned to either the treatment or the placebo. You can't do that if you're looking to see if cannabis causes schizophrenia. You're not going to give this half of the room cannabis for the next 20 years and this half placebo and see who gets schizophrenia. So those studies are really so-called observational studies, and they lack the precision, if you will, of a randomized placebo-controlled clinical trial looking at therapeutic effectiveness. So the 11 prioritized health endpoints, both benefits and harms, that we looked for, and these are essentially the chapters in the book are listed here, and you can see that there's therapeutic effects was chapter number 4 after the introductory chapters, and all of the other chapters were looking at the literature on potential harms of cannabis. So we have 1 chapter on potential benefit and 13 chapters on potential harm, but again, when you look at the research, certainly in our country, the money is spent looking at potential harm as opposed to potential benefit. So every paper that we reviewed, meta-analysis or clinical trials, we learned about how to describe how strong the evidence is in that medical report. And the 5 levels of evidence that we utilized in making our report were conclusive, substantial, moderate, limited, or no or insufficient evidence. So let me just review in my time remaining some of the highlights of some of the chapters. So with regards, and I'm going to focus because I am somebody interested in the therapeutic benefits on the benefits as opposed to the harms, but I will touch on some of the harms. So conclusive or substantial evidence of effect in therapeutic benefit. So for this level of evidence, there are many for conclusive or several for substantial evidence, supportive findings from good quality studies with no credible opposing findings. A firm conclusion can be made, and the limitations to the evidence can be ruled out with reasonable confidence. So we concluded that for treatment of chronic pain in adults, cannabis and cannabinoids were effective treatments. That's why sometimes in the United States, states decide what indications they're going to allow patients to use medical cannabis for, and states that don't allow it for pain, it just doesn't make sense to me. From what we know about our own system of cannabinoid receptors and our endogenous cannabinoids, I think that whole system is there to help us modulate our experience of pain. So it makes good sense that cannabis is very useful for pain. The other indication for which we found conclusive or substantial evidence was for anti-nausea therapy in patients receiving chemotherapy. And that evidence was mainly from the licensed and approved dronabinol and nabilone, which are delta-9 THC preparations, which have been approved in our country since 1986 for the treatment of chemotherapy-induced nausea and vomiting. And then there's also the spasticity in patients with multiple sclerosis. And studies have shown that oral cannabinoids, as well as the nabiximols, which is the whole plant extract with a 1-to-1 ratio of THC to CBD, licensed and approved and available from pharmacies in the United Kingdom, European Union, and Canada because of the results in benefiting patients with multiple sclerosis and spasticity. So those are the therapeutic areas in which we found the most evidence of effect. For moderate evidence of effect, there were several findings from good to fair quality studies. So the studies are not quite as strong, with few or no credible opposing findings. So we found in this category only one outcome, which was sleep. And I think most of us are going to agree that cannabis is useful for sleep, although no clinical trial really has looked at that. The studies that we found in the literature were again of delta-9 THC, as well as the nabiximols, the under-the-tongue spray. We recently did a study of patients using cannabidiol in San Francisco, San Diego, and Chicago in 3 integrative medicine clinics, as well as 10 dispensaries in those 3 cities. And because there's such a paucity of data in the medical literature on what cannabidiol actually does, we asked patients using CBD-dominant products what they were using, how they were using it, and if it worked. And mainly we found that people were using it for pain, sleep, and anxiety. So not only cannabis and THC, but CBD may have some benefit, at least in that observational study for patients with sleep issues. Now, this list is going to surprise and anger you probably, like it did me, but no or insufficient evidence was our biggest list. Because for this level of evidence, there are either mixed findings, a single poor study, or the health endpoint has not been studied at all and published in the medical literature. So these include cancers, and yesterday, for those of you that were here, I spoke about cannabis and its anti-cancer activity in the test tube against particularly rat brain tumors. But this is not translated into any human clinical trial that's been published in the medical literature that shows that cannabis has any effect against any cancer in human beings. So we said that there is no or insufficient evidence, and even loss of appetite associated with cancer. I remember the day that each day when the committee met, at the end of the day, people would come back and report to the full committee what their findings were. And the day that we came back together and we were told that there is no evidence that cannabinoids increase appetite, everybody sort of leaned forward and said, what? Because I think most people had gone to college and probably had experienced the munchies at some point in their life. And the answer was that the studies were all of delta-9 THC. And cannabis, as you know, is a very different medicine than THC alone. There were really no studies in the medical literature looking at cannabis and the effect on cancer-related weight loss. Irritable bowel syndrome, I think somebody just sent me an article that was just published suggesting that cannabinoids, particularly again maybe cannabidiol, may have activity in irritable bowel syndrome, but as yet, when we did this review at the end of 2016, there was no such study published. Similarly, epilepsy. We now have Epidiolex licensed and approved in our country for the treatment of these unusual seizure disorders in children, and that is cannabidiol. But up until 2017 and 2018, there was no significant literature published in the medical journals supporting cannabinoids for epilepsy, even though the Institute of Medicine suggested that research be done back in 1982. Spasticity in patients with paralysis due to spinal cord injury, and then a number of neurodegenerative diseases, including ALS, Huntington's, Parkinson's, which we heard about earlier, and dystonia, which is another movement disorder. Also felt that there's no evidence that cannabis is useful in achieving abstinence in the use of addictive substances. And I'm not sure that, that means, I'll just say right now that I believe that the absence of evidence is not evidence of absence of effectiveness. And just because it's not published yet in the medical literature doesn't mean that it's not effective. And I think more and more in the states in our country where cannabis has been licensed and approved either as medicine or recreational, we're seeing decreased use of opiates and decreased death from opiates. So I don't know, abstinence maybe is too strong a word, or none of these studies have yet been published in the medical literature at the time that we did this report, but I would not eliminate this as a potential benefit of cannabis, and particularly a cannabinoid called tetrahydrocannabivirine, or THCV, has been found to decrease appetite in general for food, for tobacco, as well as for opiates. So I think tetrahydrocannabivirine is a cannabinoid that we're probably going to hear more about. In our therapeutics chapter, we said that there was no benefit of cannabis in patients with schizophrenia. However, in the mental health chapter, the people that wrote that, and this was a little bit of an inconsistency, said that cannabinoids actually benefit the thought processes of schizophrenics. So, yeah, let me turn to the mental health chapter because this created a bit of a buzz. There is substantial evidence of a statistical association between cannabis use and the development of schizophrenia, with the highest risk among the most frequent users. And people have run with this. People have said that cannabis is associated with schizophrenia for decades. If you look at the rates of schizophrenia around the world, it's 1% for the adult population, regardless if it's in a country like Jamaica, where there's heavy cannabis use, or the Soviet Union. And over time, it stayed at 1%. It didn't go up to 15% in the 60s and 70s in the United States when people were using cannabis. So this statistical association, I believe, is because young people who have a thought disorder find that cannabis improves their thinking, and they use cannabis, and then they get diagnosed with schizophrenia. So it's not causal, the association, but it's a therapeutic self-medication association. And again, this is what they reported as their second finding, that in individuals with schizophrenia and other psychoses, a history of cannabis use may be linked to better performance on learning and memory tasks, sort of supporting the hypothesis that I just produced for you. Cannabis use does not appear to increase the likelihood of developing depression, anxiety, or PTSD. For individuals diagnosed with bipolar disorder, near daily cannabis use may be linked to greater symptoms of bipolar disorder. Heavy cannabis users are more likely to report thoughts of suicide than non-users, and regular cannabis use is likely to increase the risk of developing social anxiety, although interestingly, CBD has been shown to decrease social anxiety. Let me just talk about post-traumatic stress PTSD. People have been trying to do clinical trials of cannabis in patients with PTSD, and they have not proven to be of benefit. And this, I think, is one of the issues that we're going to face as clinical investigators trying to study the health benefits of cannabis. I often say, I need a clinical trial to tell me that cannabis is useful in PTSD as much as I need a clinical trial to tell me that penicillin is an antibiotic. Look at the returning warriors from every war that we've had in the United States. All of those people use cannabis, and they're using it for their PTSD. But trying to do a clinical trial, again, randomly assigning this half of people with PTSD to smoke cannabis or eat cannabis or take a cannabis tincture, what are you going to study? Or this half to take the placebo, I don't think it's going to produce, I don't mean to be sort of depressing and say that we can't really study this anymore because there are too many options out there, but it's something I think we need to think about. I think cannabis is very useful for PTSD. Are we ever going to generate the evidence to demonstrate that? Respiratory disease. My friend and colleague Donald Tashkin at the University of California, Los Angeles, has been funded by NIDA for 40 years to study the harmful pulmonary effects of inhaling cannabis, and he really can't find anything. It produces a little more sputum and cough. Otherwise, we found no evidence of bad outcomes in people who use cannabis regularly. Some article just came out that cannabis use increases the risk of stroke. We did not find that. We reviewed, again, many years of published literature and found no evidence that cannabis use is associated with heart attack, stroke, or diabetes, and in fact, it appears to decrease the risk of diabetes. Cancer, again, I told you that I don't think cannabis cures cancer. I don't think cannabis causes cancer either, and this was a little bit of a surprise and somewhat of a jolt to one of our sponsors who thought that maybe it did. But again, Donald Tashkin did a study of 1,500 people with upper aerodigestive malignancies in the Los Angeles basin and found that people who use cannabis lightly over time had a 37% reduction in the risk of developing lung cancer compared to people who never used cannabis. Similarly, cannabis use is not associated with an increased incidence of head and neck cancer. And yesterday I described this association, the limited evidence of a statistical association between use of cannabis and development of testicular cancer. And I described it by saying, who gets testicular cancer? Young men. And who smokes cannabis? Young men. So that is a statistical association, but it is not a causative association. Yesterday I said it's very similar to the finding that there are increased drowning deaths in months where ice cream is overconsumed. It's true, and unrelated. This was also a very hot button issue, what happens to babies and women who smoke cannabis. I kept saying, can't we look at Jamaica? Don't they have normal babies? And they said, no, we can't go there. So we reviewed the literature and found that smoking cannabis during pregnancy is linked to lower birth rate in the infant. The relationship between smoking cannabis during pregnancy and other pregnancy and childhood outcomes is unclear. Finally, our last chapter was a chapter on barriers to cannabis research. And there are many, including the fact that in our country, cannabis is a Schedule I substance, which means it has a high potential for abuse and no accepted medical use. And to even study it, you have to get a special license from our government, from the Drug Enforcement Administration. You have to be investigated. Your site where you're storing cannabis has to be investigated. Cannabis has to be stored in an alarmed safe that alarms to the police department. Why anybody would come to try to take NIDA's 3.9% THC cannabis is beyond me. So it is difficult to gain access to the quantity, quality, and type of cannabis necessary. We need funders, and to develop conclusive evidence, improvements in standardization and research methodology are needed. So in conclusion, the findings with the strongest evidence, initiating cannabis use at a young age is a risk factor for problematic cannabis use. Pregnant women who smoke cannabis increase the risk that their baby will be born with a lower birth weight. Long-term cannabis smoking causes breathing problems. and some people with chronic pain, muscle spasms from multiple sclerosis, or nausea and vomiting from cancer chemotherapy obtain relief of their symptoms from using cannabis-based products. Researchers who want to study the effects of cannabis face substantial obstacles, and those are things that I've been dealing with for the past 22 years. So my plea is for those of you in the audience involved in the industry to please try to figure out how to generate more research from this, the plant, which is nature's medicine. Thank you for your attention. Professor John of Abrams. That's fantastic.